we might start first of all. Jennifer, so you're on the tender evaluation team and you discovered the joy of travelling with me, which is no sleep and far too many days to work. And you saw Epic being used in a variety of other health services. As you've worked, I suppose, across the whole ACT public health system in clinical, administrative and management roles, what are your main concerns about the implementation of the Epic and the DHR in the ACT?
My mic's on, yeah.
Yep.
Firstly, I guess I'd like to reassure people, if you haven't been reassured already from the previous speakers, that my main concern does not relate to the Epic system at all. All the sites that I visited, Peter, and you visited too, as you know, reassured us of how configurable it is to our requirements. It's so exceptionally configurable that probably the other issue is keeping things standardized. And they have a proven success record in hundreds of organizations for the last 4 decades. So it's not at all my concern for the Epic system. All my concerns relate to the change management process. And if I may be a little bit more specific, to roll out a project of this enormity will require pretty much all of us in the healthcare system to be engaged in some form. Not just the SMEs, but we'll be training, people will be asked some information, and much of that will be at very short notice. So Peter did apologise earlier on. It is necessary to build this system as best as we can and as safest as we can on go live. So the successful implementation does require us to be respectful with one another and compassionate with one another as well for this big project. It is already going to be tough enough as it is. So we want to hold steadfast in our organisational values as we relate to each other as well, hopefully in kindness and compassion as we go forward. So that is one of my biggest concerns. A second concern I have relates more to the build and joining the dots. So we will be the first in the nation to implement an Epic PAS system. There's a lot of work around that in capturing the information that we require. Of course, that needs to be integrated and linked to the patient assessments and the patient interventions and treatments that we do, which will then need to link that information with the analytics and reporting as well. So Justine is here, and so she knows, I know that you are worried about this. So that reporting is of course required for legislative requirements, for funding, cost recovery, etc. And those dots need to join together in the build and to have that bird's eye view, not just the siloed view as this is my territory, that's all I care for. It does need to go across as well. The third one, and I'm glad Kath spoke because I've had this concern, as you know, Peter, from the very start, is the governance of allied health. Allied health in the ACT is special with 30 or so different disciplines across the territory, and governing that and making sure that all the individual disciplines are catered to, but at the same time there are certain things that need to be standardized so that we do compare apples with apples. For example, allied health is very much involved with group programs. So are those group programs being captured the same way across allied health? And the final one is becoming less of a concern, Peter, mainly because of your reassurances to me, and that is essentially the upgrading of very old infrastructure and the upgrading of devices too. And I'm especially concerned, of course, from my home in Calvary. Some of the older buildings across the territory are in Calvary facilities, but I do know that there's work in progress to get that upgraded well in time before go live. Now, saying all these concerns, I know for a fact that the digital health record team is led by some very dynamic, very bright and highly resilient leaders. These guys didn't sleep at all. I'm sure they didn't sleep at all during the tender process. I also am very much assured from the site visits and from our recent interactions with the EPIC team that they are amazing. They'll be holding our hand along the way. They're so helpful, and you can clearly see their culture is absolutely exemplary. And I know for a fact as well that in the audience today and at the operational level, we have exceptional clinical and non-clinical leaders who I'm really hoping that we'll all band together for something that will transform and contemporize our healthcare service right across the territory.
Wonderful. I get the feeling that speech just cost me more money somehow, but anyway. Thanks, Jennifer. And look, for those of you who haven't seen Level 4 at Calvary at the Xavier building, brand new ICT network going in, brand new nurse call system that's rolling out across Xavier, going through mental health and ED and so forth. So I think it's really good to see that investment in the infrastructure. Canberra Health Services were out to roll out 2,000 clinical work devices, so clinical grade smartphones. It's really exciting to see this ongoing investment in infrastructure across the territory, so I think it really sets us up well. Continuing across the stage, because that way it helps me keep in mind where I'm up to. Dean, we've heard a little bit about sort of MyChart, the patient portal today from Epic, and we're going to implement that in the ACT, so it's a website and secure portal and also apps for those with phones. It'll give consumers a lot more visibility of their own health information, upcoming appointments, results and so forth. What do you see some of the opportunities of utilising that technology in the future could actually bring for patients and their own sort of control their own destiny?
Thanks, Peter. So first a disclaimer. So some of these will be a little bit pie in the sky and some of them will actually probably already be in the system, but I won't be aware of them just yet. So I think it's across sort of three main areas. I think we want to help people understand, we want to help people connect, and we want to help people to help each other. So going through some of those, what I mean by that, so we've got lots of opportunity for changing how we engage with health professionals. So there's opportunities for a bit more prep work to happen before a consultation occurs. There's opportunities for sharing information with consumers and helping connect and link them to other information, so you can connect people to the instructions for use, you can connect people to various lists of side effects and that sort of thing. But that's all relatively basic. What I'm really hoping that this can do over time is help people understand where they fit in the bigger picture, help people understand what steps they could be taking next, and help people know what their clinicians are looking for from them. With the potential even for sort of two-way communication at some point in the future, should funding models ever support that sort of approach to work. In terms of help, I'd like to see, you could use something like this to even show people opportunities to help more within their health system. So it could be as simple as just letting them give some feedback, or it could be as complex as, would you like to join this design project to improve this particular part of our health system? So there are opportunities for other ways of engaging with people beyond just the sort of more standard ways that we've become used to. This is going to be slightly heretical for someone from health consumers to say, but there are more ways to engage than through governance committees and even basic user research. There's opportunities for finding ideas out among the public, even among health professionals, and then combining them, bringing them together, and driving innovation that way, not just through the more formal processes that we're used to. And in terms of connecting, I mean, there's always a question with any platform about where you draw the boundaries of the interface and where you let people take information out and bring it back in. There's always going to need to be carefully managed, but I think there's a lot of scope potentially for helping people understand how to engage with other processes they might need to get help with. So there's social prescribing, which was mentioned, but there's more specifically things like helping them prepare for an NDIS assessment, helping them collect their information for workers' compensation or similar, which would then, when we take that sort of approach, we're looking at a method of engaging people that isn't just about the points along the way. So it's not just about the appointments or whatever else. It's about what are your outcomes that you're trying to achieve, and it's about what issue are you trying to solve. All those little dots make up that bigger picture. So by bringing that together and by even changing how we communicate and think about it, I think we're going to end up at a much more consumer-centred system purely through taking a more longitudinal approach to how we're trying to improve people's health.
Excellent. I think it's an exciting world we're looking forward to. And I must also confess the other bit of news is that we start work next month on do the design work for the MyChart, the patient portal, to kick that work off. So we're starting in front and centre with the project, focused around what healthcare consumers see and how it will work for them. So I think that should hopefully set up the program really well for the future. So looking forward to working very closely with Healthcare Consumers Association, but also outside governance committees, very much so. Continuing along, Nick, doctors at times can be very reluctant to move from using their own specialty clinical systems that they've spent many years sort of perfecting and getting just where they need it to be, across to an integrated digital health record. What would you say to sort of those doctors who are watching, who are feeling anxious about moving away from their bespoke clinical systems for their specialty to a more general sort of DHR?
Oh, well, I guess, Peter, the first thing I'd say is I completely acknowledge that a lot of people have put a lot of time into designing these in such a way that really fits the needs of their patients. So that's the first thing. Then I would say that from what I've heard today, and I'm learning about Epic as well every time I go to a new thing like this, is that there's no barrier in using what you've created to be part of Epic. You've got the foundation system, but there's an ability to take your experience and build something really cool. It's just that everybody else gets to see it. And that to me is the most important thing. I mean, to be honest, there are things that I need to see about my patients in infectious diseases that sit in other databases, and I can't give them the care that I need because it's not fully integrated. So whilst there may appear to be a cost, some of that cost can be mitigated. And the other thing is, of course, that means involvement and engagement. So that if you're listening or you're in the room and you have your own systems for your own craft group patients, then the answer is to influence the process by being involved both at the unit level, and of course your units will need individuals and subject matter experts. I just wanted to say there one other thing, just sort of pivoting a little bit to clinical engagement and what that looks like. Firstly, this is going to be, it is clearly going to be a difficult process with very set timeframes. But one of the ways to keep engaged, I think, that resonated with me was the idea that we just reinforced that this is a clinical project. This is the biggest clinical project we've ever done, and I hadn't seen it framed like that. That was really helpful. It's not an IT project. You'll hear me, I think now I will just be saying that every day for the next 365 days. That means really that we want everybody to be given the time and the space to be able to do this, and that means that at an executive level, we need to make sure together that we have a common understanding of what that means for individual clinicians and unit directors, what it means for people taking time off. In those, Peter said, there are going to be periods where you don't hear from Epic at all. And then there will be some very concentrated periods where you might not get to see a patient for a couple of days. Now, what does that mean? How much assistance do we provide? Lots in helping plan for that in advance, so our subject matter experts can be made available. So that's something that I'll definitely be focused on, and I know that my colleagues, the clinical executive directors, are also aware of that.
Excellent. I think I need to put something on the bottom of my email signature block. This is not an IT project. And I think if that's the number one thing that everyone takes away from today, that really is the thing. This is not IT. This is not about widgets. This is about patients and about clinicians, and this is a clinical transformation project. So thank you for that, Nick. Tony, nurses and midwives are probably the largest cohort of sort of the health workforce, and we have many who work across a range of different settings in Canberra, sort of justice health right through to community health, and then through to sort of the most acute services that are offered. How do you think the ability to access patient information on mobile devices will change those workflows?
I think that the beauty of Epic, having previous experience in implementing electronic medical record, is that you'll be able to capture the patient experience from the time they come to the emergency department through the intensive care into the ward and then back into the community. And that point of care where a nurse or a midwife can drill down at that particular point of care will ensure decreased risk to the client. And I think that is the beauty of Epic. I also think by using your own devices that there's a greater aspect in relation to confidentiality, and because in previous IT platforms you've been able to go and access other clients' medical records. I also believe that within Epic they've safeguarded the nurse and midwife not to cut and paste, and there's a safeguard on the time frame that you can log in and out. So they are some of the experiences that I've experienced that have left an organisation vulnerable, but above all, having to translate patient care does lead then to a decrease in continuity of care, and that translation leaves the patient exposed. But I do think that the nurse and midwife will be able to drill down to point of care at that particular time to ensure that they have an appreciation of the multidisciplinary care plan that nurses and midwives do execute, because they are there 24/7. So I think it's a great concept. I think you need to be congratulated. And the only other aspect that I would like just to highlight is that some I think we may forget, or maybe not fully appreciate, that not all nurses and midwives are IT savvy, and that even the basics of turning on the computer, and I'm talking for myself. I've always had a secretary, so I've been blessed. But I think if you pitch some of the education up here, which we did, I think there's some fundamental of IT platform that you really need to appreciate to get the full benefits out of Epic, or as we'll try and find a workaround. But I do think it will change the way we work. I think it will enhance the patient experience. But the fact that a nurse and midwife can drill down to point of care at that particular time with a full clinical picture will really enhance the patient experience. It will decrease fragmentation and duplication, and provide efficiencies for nurses and midwives to really ensure best practice and safe practice at the bedside.
Excellent. I think the range of tools we're going to give nurses to really help them in a system, I think it's going to be like a revelation that they've suddenly got access to all this information we've never made available to them before. Yeah. And I think there's almost, for me, the most exciting part of that also is the community nurses at the moment, where often they'll go out and sort of the healthcare consumer keeps the file at home, staff member travels from point to point and the file stays in their home. The fact that that's going to be revolutionised, and these staff will be able to do it on a smartphone as they go out to their home, sort of record it, take a photo of the wound, check medications, look up results, all while providing that clinical care, I think will really transform that care. So I think it's a really exciting thing.
Also, I think it will strengthen other services where some people may be vulnerable, such as hospital and the home, where they know they'll have a connectedness to the acute care sector. The medical team can also be involved. So I really do think the benefits from a community perspective, primary and community health, and hospital and the home is where care should be, will be strengthened because of Epic. And so there have, as I said previously, not all systems have always in other states and territories been an interface, but this will, and I think it would be wonderful if we commence some form of research from the outset of your implementation and the findings with some KPIs to measure the success. But our learned colleague down here had it exactly right. If we start off in stages with what's the intent of Epic and then build upon the platforms, I think the last thing you want is staff to be so overwhelmed and disillusioned that they're learning about the IT system, not necessarily the full benefits of a staged approach, which you have planned, Peter, and are supported by the team, is excellent.
Excellent. I don't think I need to give everyone $20 as you leave tonight. Done well.
But however,
that can cost me a whole lot more looking across the room. So a question, I'll let any of the panellists here decide who wants to chime in on this one. Clinical leadership may talk about patient experience, but often takes action based mostly on regulatory compliance needs. How can the DHR change this?
Can you just repeat the question?
Clinical leadership may talk about patient experience, but often takes action based mostly on regulatory compliance needs. So how can the DHR change that focus?
Well, I'm happy to go first, but I think we should all answer, just spread the load a little bit. I guess I see where the premise of the question's coming from, and I think that if we, what data points are we trying to get out of the DHR to improve care? This is about things that we already have to demonstrate, adherence to national standards, because our quality and safety standards do actually form a really strong base from where we can deliver high quality, exceptional patient care. So I'm not sure if the question was framed to include those as the sort of regulatory compliance sort of things, but I don't see them so much as regulatory compliance, but the building blocks of quality patient care. So I think for me it's about changing the focus into what are we defining, what are the national definitions of quality patient care, and we've got things that we need to report against. But then we've got the opportunity to define what we think is excellent patient care and innovative patient care, and I think the DHR has the opportunity to really enable that sort of process.
I agree. I think it will further enhance compliance, and it's the way that we develop the EPIC platform to capture and ensure safeguard quality care to our clients. So I think at the moment it's quite fluid, and to be honest, I've only been here recently. It's very hard to ascertain data. There's a lot of data systems, so I think this will actually secure and enhance compliance, and we'll be able to build the platforms against legislation, policy, procedure that will safeguard good patient care, but also the reputational risk of the organisation. So I think it will enhance same.
It's the clinicians are building the system, not the legislators. And also EPIC have excellent clinical decision tools as well that has been based on best practice, and we'll be looking at those tools and building on that as well. And you've seen from the outcome data from the other facilities that have implemented EPIC, none of that really relates to legislation. It's about patients and it's about staff. So I'm not worried about that aspect at all, although it's important to look at the legislation and whatnot, but this really is a clinical project.
Absolutely, and clearly someone's thinking I'm getting off lightly here, because I've got a question that says, Peter, do you think CHS presents any particular or unique challenges in terms of this EPIC installation? The answer is yes. CHS is a big health system, a health service that provides a whole range of services, everything from sort of community-based services right through to sort of the subacute, the acute, justice health, alcohol and drug services. The complete range of disciplines and services provided by CHS is absolutely a challenge. Is it insurmountable? No. Is it going to make us all work harder? Yes. But does it also hopefully mean that we'll actually have a more joined up solution that actually is focused on the individual patients at the heart of everything?
Yeah.
I would have said yes. So do I think it presents a challenge? That's it. Nick?
Whilst we're getting the mic to Lisa up there, who's got a question, I'll just I just think also it's clearly that's a great question. The person who posed the question has had some challenges in mind, and they should be clearly articulated and acknowledged. The ones that come to my mind is we're constructing this from the ACT Health Directorate, and CHS is a different directorate. But this is a really good example of coming together, and I'm starting to engage with colleagues that I haven't worked with before, so I think that's surmountable. I think the medical engagement is a real issue. We know it is within the organisation. So how do we generate that excitement? And that applies as much to building the CSB as it does to Epic. So I'm thinking I leave these, presentations very, very charged and excited about the possibilities, but it's no good if that's not a shared sort of thing. So medical engagement's important. We're beyond medicine. We're going through some incremental improvements in our culture, which we see in our pulse surveys, but that's going to impact. So we got to be clear about calling those roadblocks out, because otherwise we're not going to be able to get over them, and definitely not papering over them. And if people have those sort of concerns, then raise them. Ask how it's going to be addressed, but also suggest some ways that it might be addressed as well.
I think I'd just like to add to that, and similar to the last question as well. I mean, regulatory compliance is about meeting the minimum bar, but I've not met many clinicians, health professionals or consumers that are happy with just the minimum. So the more opportunities we can create for continuous improvement, for fixing both the micro and the macro issues that we all can recognise, the more we're going to be able to bring the whole system up towards the top of what's possible, not just meeting that minimum standard.
Absolutely.
And I think if the benefits, the true benefits of Epic are promoted at a medical staff council, I think they will see a connectedness between specialties. And I'm not talking for Canberra Health Services, but where hence I came, they were a big hospital and they worked in silos, they worked in divisions. And if you are in Justice Health, there are some complex mental health issues that need to be addressed. So that referral pathway, that connected with an acute mental health team to support clients who are in a Justice Health environment is one example of how that can further enhance the experience due to our recovery. And if there is an interface with the patient journey boards, then that will just be absolutely excellent, that we'll be able to cross-reference our referrals, and the registrar will be able to go online and see the patient experience and why, or what the history is. So I think it will create a greater connectedness within the organisational structure that sometimes can be focused within their specialty. And cancer and palliative care, for example, or reaching out to Calvary because they've got a palliative care service, and some of it is driven through Canberra Health. So I think there will be the flow-on benefits of a greater connectedness between ACT Health, Calvary and Canberra Health Services.
Absolutely. So, Lisa, up the back, we've left you sitting there with the microphone for too long. Let's go.
No, that's all right. Thank you for flagging my waving hand, Nick. My name's Lisa Bell. I'm the Acting Health Director at Calvary Hospital. As a clinician, so I've worked in the ACT for 17 years. As a clinician, I constantly, every day, are frustrated on our crazy electronic record system that ICU and CCU have at Calvary versus the paper-based system. Get frustrated at a whole lot of things that happen with patients as they are going through their illness that seem to drop off from one day to the next. So someone flags something on day 1 or day 4, but by day 7, and Dean, yes, I'm really sorry to flag this, and you probably know this happens anyway. But by day 7, those things that were flagged on day 1 or day 4 have actually been forgotten about. And so the concept of a digital health record is so exciting because I have this fantastic, image of those things not getting lost. But I wonder how that, from a practical point, so maybe, and I'm terribly sorry, but I've forgotten your name from Epic, might be able to describe how that, from a practical point of view, is flagged so that I, as a clinician, and my colleagues, nursing, medical, allied health, all of them, pharmacy, need to throw in there, can go in when they go to see the patient. There's a little list that, sort of like an action item in a meeting was what I've always had in my head, that you go in and it says, oh, this has been done, this hasn't been done, this has half been done, this is due by then because otherwise that can't happen. So that sort of concept?
Glad you asked the question, Lisa. I'm Mallory from the Epic team, and I am so excited for you to actually get to see Epic. I think one of the things that we're really excited about for the direction sessions that are coming up in March and April that Peter mentioned earlier, and also some of the engagement sessions that Rowan and our team have been working on planning, is an opportunity for you to see it. In Epic, we have a couple of things that I'll highlight as starters, and then you'll get so much more information, but the first is probably the patient storyboard. So those critical things that you always need to know, we've designed, and we redesigned this about 5 years ago because of your feedback, because we had clinicians saying, man, this is pretty good, but it's not quite right. So we redesigned it, and we have a patient storyboard that wherever you are, whoever you are, whatever department you're in, you always have the patient storyboard. And included in that are those key things that can't get lost. Those are the things that they transcend episode, event, encounter, person. Those are those things that are the most important, always in your storyboard. We have a couple of different things from a clinical perspective. So we have the thing, it's called the nurse brain, which is sort of your task list of all of the things that can't get lost and the documentation about how they get done and how far they're done. Pharmacists have access to that so they can see. That's also attached to our longitudinal medication record called the MAR. We use a lot of acronyms, so I'm sorry in advance, but you'll get to see all of those things, but the MAR also does some of that longitudinal tracking, and then it all kind of wraps it into the single patient view. There's a lot of other things that have tick boxes and appropriate recording fields and flags and red colors when they're wrong, or amber colors when you're getting close to missing a next step that you needed to take at a certain time. But I think that storyboard, along with some of those other tools, really do a lot of what you're talking about. I think, Nick, to your point, though, some of those specifics are really important for us as we go through this implementation process. So if you know in your units you've had struggles with these 3 things over and over again, and you're like, how do we keep missing this? Bring those things up, because we want to make sure that if those are things that have historically been a problem, we're really intentional about flagging those also. Hopefully that helped answer your question.
Yeah, no, that's fantastic. And I'm also very, very looking forward to spending 5 minutes looking at where things are at for that patient rather than the half an hour, 40 minutes that I take when I go and do a consult and trying to track through, especially the long stay patients, and you're trying to go back through and you discover 3 weeks back this fantastic summary, often from the ID specialists, where...
Look at that flattery.
Yeah. Where, there's all this detail. Well, it's because I'm an ex-ED physician, you see. I'm a concept, not detail person. And there's all this detail, but then it hasn't been transferred. So, it's very exciting.
Peter mentioned that Mayo Clinic thing. That was actually one of the things that we worked on really, really hard. At the same time we were designing the storyboard, is they're seeing sometimes the most complex patients that many of the surrounding healthcare organizations are seeing. And I have many people that I'm sure would love to talk to you about what has worked and what hasn't. But that is something too that I think over time we've done we weren't always great at it. And sometimes you make decisions that make it not so great. And sometimes we'll tell you that's a bad decision. You shouldn't do that. But a lot of times you'll come up with a really great idea and something creative that we'll want to add.
Wonderful. Look, thanks for that, Mallory. Next question from the audience.
Thank you for this symposium. My name's Seema. I'm one of the residents at the Canberra Hospital. Thank you, Nick, for mentioning roadblocks. I think just looking around, I'm probably the only junior doctor here today, and I was just wondering whether you had any thoughts about how we can engage the junior doctor community in getting on board with the DHR.
Thank you, Seema. That's such a pertinent question, and you and I had the same thought. And I was furiously trying to copy the Vimeo link into the JMO WhatsApp group, but it turns out that the security protocols prevented me from doing that.
I have an app for that. Lingo's coming in a couple of months.
But I mean, it's a serious thing, because I had the same thought. I did try and do that, and then I thought, we need to actually use this as a case study. How many, how many junior doctors are watching this online? How many were actually aware of it? I'll ask these questions at the webinar on Wednesday. But then there is the improving medical engagement and communication strategy. So we do have regular webinars. This, like hand hygiene, will be the first 2 slides going forward until it's finished. We need to work out some communications etiquette. I mean, we've got lingo coming up. That's actually a priority. But going in, lingo sort of merges with Epic because Epic's got the same functionality. So as a junior doctor, and things have changed. But the only thing that was useful about a pager was that even though it was buzzing, you could at least have the choice that what you were doing needed to be prioritised. Whereas this is just going to give you a stack of information and tasks and things to do, and we've really got to work together, particularly ward nursing staff and junior medical officers, and also senior medical officers, because we'll be contacted and been doing the contacting, understand what our communications etiquette is. So one of the things that I'd really like to hear from the EPIC team is, have other institutions around the world faced that problem of information overload, task overload, and that sort of thing? It's just one example.
But for the future, though, for the future doctors and nurses coming through the universities, they'll be exposed to EPIC and the electronic medical record from the first year of nursing and medicine right through until they graduate. So that transition for our future workforce in the health arena, as well as allied health, will be a decrease because they'll have their own unique identifier, and it will be, they'll have a greater appreciation of the benefits because it will be part of their curriculum.
I'd just like to add as well, I think from a design perspective, I'm really hoping that as we go and build this out, we're really able to leverage the fact that some of the more junior people, some of the younger among us, where our brains have in some way started to change. They call it like the Google effect or Googleification. We don't remember the information itself so much as where to go to find the information. So a system like Epic, where the information has to be somewhere, the more that the juniors can be involved with setting up that ontology or the knowledge graph or whatever else, how the data model essentially for where information is going to be, the more they can be involved, the better the system's going to be.
Absolutely, and look, I think Rowan Essex, who will be outside taking questions afterwards, also has been focusing on this a lot with sort of how do we sort of engage, because they are the backbone of our workforce, and they will be becoming our seniors very soon. Got time for 2 last questions, and I'm going to wrap up. So first of all, one from the audience, and I've got one more from online.
Yeah. So my name is Elijah Maham. I'm from Calvary Hospital. I work with Robin. The question is just to Mallory, and healthcare is quite new into the cyberspace. The banking sector and then various other organizations have had their own dealings with ransomware. So just wondering, over the years you guys have been operating, this is not specific to just ACT, that all of a sudden we are moving most of our transactions to online, and then we get a ransomware. Have you had experience in that? Or I'm sure you're prepared for that, Peter, but just saying that if it happens tomorrow, have you had experience? What are the kind of things in place for that? Yeah.
And while Mallory gets the microphone, I might start and say there's probably more money spent in the healthcare sector in the ACT government on cybersecurity than the rest of the ACT government combined 3 or 4 times over. And so, look, it is a thing that we do take very seriously. Am I spending enough money on it? No. The answer is you can probably never really spend enough money in cybersecurity, but it is a very big focus of what we're doing, and we now have a team of about 8 people who that's all they do all day, every day. But Mallory knows far more about the joys that Epic have dealt with some very special people over the years.
They're all special, Peter, all of them. It's a great question. I think a couple of things that I think are probably most pertinent, and then I can share a little bit of our experiences. We, as a part of our software development lifecycle, we actually do security testing and security design reviews at each stage in the development lifecycle. We have the gamut of independent auditors. We have a team at Epic who, similar to the 8 that Peter has, they just work on trying to break into Epic. So finding all of the ways to try and do bad things, in summary. So we work through that on a regular basis. We'll keep you informed if we ever see any potential vulnerabilities, and provide you support and or coding to fix it. So I think just fundamentally that's built into who we are and how we develop. We have seen a couple of groups be impacted by overall ransomware attacks. They typically are actually not coming direct to Epic. So some other part of their healthcare network is being impacted. One time was working with a group who ended up getting, they were attacked. They had a ransomware attack, and we shut everything down while they could figure out what to do. And we sent a team of people out there to help them, and it actually, none of their Epic data was breached. It wasn't anything through Epic, but it affected their whole network, and they were worried that something would happen. So we have certain protocols depending on what happens. We've worked with many groups who've been in various stages. And interestingly, in this region, I have found that the world is in various stages of acceptance of the changing security needs in the industry, even within healthcare. So talking to one of your peers and your counterparts in Singapore, you will get a different perspective on security and the stringent measures that need to happen than you might from a peer at CU at Cambridge with Keith and Afzal, or another group even at Parkville. Even at Parkville, you'll hear something a little bit different. So I would say in general, it's a very important thing to us. It is part of what we do every day. We have lots of procedures and opportunities to support you if for some reason you were to be impacted. In my decade of working at Epic, we haven't had a meaningful breach that wasn't caused by a disgruntled employee at the customer site or somebody intentionally doing something malicious from within the organization. So that's probably the best assurance I can give you today.
And the last thing probably to add is that in the next month or two, we actually stand up a dedicated 24/7 security operations centre. So part of the work we've been doing with actually going live with Epic is also working on getting new hosting arrangements. So we're actually moving to what we're calling the Health Protected Enclave, our own separate secured hosting environment that's hosted using a whole range of very sensitive things that do a whole lot of things. Not really going to talk about those in this big open forum. Happy to have individual chats outside where I'm not being recorded and broadcast on the internet. Suffice to say, however, we will have we've got an outsourced 24/7 eyes on glass, people sitting there watching for alerts and triggers constantly, in addition to the team that we have inside ACT Health, in addition to the team that shared services have, and in addition to the team and the support we get from Epic as well. So nothing is ever perfect, but I can assure you it's a very large part of the focus of my day-to-day job. So one very last question, which we'll spend 2 minutes on only, and Rowan, I might call on you to also be part of the answering of this one, given we've had lots of conversations about this. In the US emergency departments, there is concern about the negative effects of digital health records and data entry on clinician wellbeing. How are we planning to avoid that in this implementation? The overload of clinical documentation.
Yeah, you're not planning on answering that question at all, are you, Peter?
No, but Nick might.
It is a known issue with digital health transformation that there is a dip in clinician, and we're not just talking about doctors, happiness, and we saw that on all the graphs up there. Look, a huge focus is this. Change management, training, getting people familiar with the system, realistic expectations. And we do plan, and we've touched on this, Nick, we do need to deliberately try and throttle activity a little bit as we go live, just so to take the pressure off. We're all pretty much on our limits day to day anyway. We can't do that and something new. Just pull it back. It doesn't have to be 50%, but a touch. I know Epic don't like us to do this, but literally every site we've spoken to has planned this, and none of them have said it's a bad idea. 2 to 4 weeks, I think, is enough to get people over that, my God, what am I looking at? There will be clinicians who do not want to change, and they will always be a challenge and probably unhappy My job is to work with them one-on-one, I guess.
So does anyone else want to add to this one while I completely dodge it?
An important factor is that the benefits need to accrue to the people that are doing the extra work. Otherwise, there's no motivation to keep continuing to do that work. So as long as that's a design principle that's taken forward as we go through this process, I think people will come around relatively quickly.
Last thing, and then I will give it back to you, Peter. This is a really important part where we need your help. So we design the foundation system, your initial workflows, and they're designed to be efficient and to have people documenting things one time. But sometimes we don't know exactly who at your organization used to document that. So one of the things we've found over our time implementing is sometimes we assume somebody is the person who normally does that documentation, and in reality they don't. So they might feel they have a larger burden than others to carry when we actually get into the stage of using Epic. So it'll be really important that you all stay engaged in that process. And if as we're going through a workflow, you say, oh, wait a minute, I'm thinking about that. And Susie, my colleague who triages my patients before I see them, she's always the one who puts that information in, not me. We need you to say something so we make sure that we're not inappropriately moving burden from one part of your workforce to another. In some cases, it makes more sense to transition, but by taking one thing on, you can give one thing maybe to somebody else and do that balance. But we'll need you to help us understand that as we get through the system design also.
Can't help myself. One final thing there will be efficiencies. There are certain parts, and transcription jumps out as a huge area where I think it was Melbourne noticed a 90% reduction in their transcription. The organisations need to be somewhat agile and potentially redistribute some of that resource to the bottlenecks, which might be the patients arriving in ED. Now they need all their medications entered, whereas previously it was a scribble. So it'll be a learning exercise for us all, but and change is coming.
And on that note, before Rowan gets the microphone, I think we'll get it cut off now. I'd like to first of all, thank everyone for attending today. Thank all the panellists and the speakers throughout the day or this afternoon. I've run woefully over time, which is, I think, good though, because there's lots of discussion. There's lots of questions we haven't answered. So next steps from here. First of all, for those that missed a presentation or missed some of the slides or didn't get a photo or didn't get to ask a question, we'll be sharing all of this online, which will be available for you to share with anyone, and we'll be promoting it very widely across the public health system. So all of the talks, all the slides, a couple of videos that were there that we didn't really get to play, we'll share all this content with you. I've got a whole list of questions here we didn't get to ask speakers and panellists. We'll get answers for all those and share that as well. But very much please recognise this is just the beginning of this trip. There will be lots of chance for you to all become engaged, and as we've heard from everyone, I think the more engaged we all are, the more we're going to implement something that actually fundamentally makes the lives of you as clinicians better, but also improves the outcomes for the patients that you deal with day in and day out, and the reason why you became a clinician in the first place. So can I say to everyone, thank you so much for your time today. Thank you to everyone who's been involved in speaking and sharing their thoughts and travelling, and Afsal, who I woke up at sort of 4 a.m. to come and talk to us this morning. Thank you so much. For those who are online, I'm terribly sorry. The food and drink that's here, I can't send virtually down the wire to you. Downside of not being here. For everyone who's in the room this afternoon at ANU, we have some food and drink straight outside. So I wish you all a lovely evening, and thank you again.